Hello and welcome everyone in today's nursing webinar session. Myself Shanti Bhattacharya from Yashoda Hospital as AVP Nursing and will be your moderator for this session today. We will be discussing the very interesting topic on AV fistula post-procedure care. The nurse's knowledge is very limited about this condition. So that's how we would like to learn today in this session from none other our expert panelist who is Dr. Prakash Goura. He is our very senior and highly competent and skilled surgeon, vascular and endovascular surgeon from Yashoda Malakpet Hospital. I welcome you, sir. And let me also welcome our very highly dedicated senior nursing manager who is Asha from Yashoda Malakpet Hospital. I welcome you, Asha.
Thank you.
So let's begin this session. The first awareness we would like to know from sir is AV fistula tend to last longer, I guess, for the dialysis patients, or we do have any other access. So we would like to know about this from you, sir.
See, for a patient who is on dialysis, we need an access to do the dialysis per se. So the best way is to have a new kidney. That is the best treatment what we can give to a patient. But it is not possible all the time and all the patients and the time what we need. Transplant takes time. So when the patient comes acutely with renal disease, renal failure, and we need dialysis, we usually tend to put an access. An access can be, as Madam said, it can be an AV fistula or an AV access, or it can be a catheter-based access. So for all the things for any matter, if we put the patient's own vein into use or the patient's own body into use, it is always giving a better result. So similarly, an AV access, in that also an arteriovenous access autogenous, that patient's own vein if we use, that gives the longest duration for a patient who is on dialysis. So apart from that, if we go to the next option will be an AV graft, wherein we put a different prosthetic graft. The least will be a catheter. So when we use the patient's own vein, that is the best option. That gives us the longest. On an average, they give around 2 to 3 years. Some patients have been doing for 7 to 8 years also.
So let us know what we have in today's session. Over to you, Asha, for the rest of the session.
Okay. Thank you.
Share the slides. Yeah, go to the second slide.
So good evening, one and all. So today I am going to discuss about the AV fistula topic. So AV fistula is a subcutaneous anastomosis of an artery to a vein. So it will be connected the artery and the vein, so the blood flow should be properly flowed.
Yeah, take the third.
So next we will discuss about the arteriovenous graft. It is a synthetic tube connected with the artery and vein. In this picture, we can see the synthetic tube is connected to artery and vein. It will help to dialysis.
So here, sir, we would like to know, as you have already mentioned, that arteriovenous fistula versus the graft. So this graft, I think the artificial tube is connected through for the access. We would like to know here for the graft.
See, the thing is, if you go to the first slide, we can see that they have used a vein. You just disconnected the vein from then, and then we have brought it down and then anastomosed to the artery.
Yes.
So that can be anywhere. It can be in the wrist, it can be in the elbow, it can be in the leg also. So that is arteriovenous fistula. Sometimes what happens is, because these patients are elderly patients, these are diabetic, their veins may not be that good. We need there are certain criteria for a vein to be used for an AV access. So if those criteria are not met, we tend to use different materials. We can use what is called the AV graft. The graft is nothing but a prosthesis tube. It's a prosthetic tube. It can be either a PTFE, that is, it is a PTFE tube, or it can be Dacron tube also sometimes. So this tube acts as a conduit between the whatever is the vein and the artery. And this tube can be used for cannulation. We can put a cannula into the tube and then connect it to the dialysis machine. So it is not in all patients need an AV graft. Only those patients who have had multiple failures, for example, the patient has undergone 3 or 4 AV fistulas, which have failed frequently, or over a period of time when the life of the fistula comes to an end, we have to change over to new fistula. When in those certain cases where there will not be enough good veins available in the upper limbs, we tend to go and use AV access. So if you go to the next picture, I can just explain.
Asha, go to the next.
Yes. Yeah. So what they have done is
Third slide. Third slide. Go to the AV graft. Yeah.
Yeah. So what they have done is they have connected one end of the tube to the vein which is available. That is a proximal vein. It is slightly above where the caliber of the vessel will be good. Along with that, we have created a loop and brought it down and connected it to the artery. Artery is the red one. So the blood will flow from the arterial side to the venous side. So this shunting happens via the prosthesis tube. And this tube, the loop can be used for inflow and outflow for the dialysis machine.
And this also is, I think, in the situ for longer time.
Ideally, what we say is it all depends on how long they perform. Ideally, the best thing is to have their own patient's own vein. The next, these usually run for around 1 to 2 years, but they usually end up, there will be some stenosis, and these need regular follow because very high chance of developing stenosis. They may need reinterventions. We need to do balloon, or sometimes they get clogged off. So we have to remove the clot and all. So those procedures, these grafts and all need regular follow, and they end up with trouble. Usually after 1 year, they usually start creating problems. But if we consider catheters, these are the better options we have. So
patient having with the AV graft, also the patient should be on the anticoagulants having this prosthesis inside.
No, because this is a high flow system, because the flow in the graft itself is very high, they don't need anticoagulation per se. These patients will be on antiplatelets, like aspirin or clopidogrel or very low dose rivaroxaban can be used. But per se, full-fledged anticoagulation is not required.
It's not required, yeah. Asha, go to the fourth slide. Fourth slide.
The second, shall I start, madam?
Yes, please.
So, two very main vascular access for dialysis, the arteriovenous fistula and the AV graft. So, mostly it will be placed week or months before the first hemodialysis, usually depend on the doctors as per the patient conditions.
So, I think these times are the pre-criteria of inserting the AV fistula is, I think, based on this condition, sir, as per your opinion.
See, ideally what we say is the approach what we have to follow is a fistula first approach. So any patient who's the CKD is categorized into CKD 1 to 5. So as soon as the patient crosses CKD 3, there are certain criteria where the patient fits into that criteria. The nephrologist starts thinking that in the next 6 months or maybe in the next 3 or 4 months, patient might need a dialysis. So that is the calculation to be done by the nephrologist. So when the nephrologist thinks that in the next 6 months, that is the ideal time. The best time is to do when the patient is stable and the patient is not on dialysis. Because once we do the AV fistula or the AV fistula, that needs a minimum of 6 weeks time for the fistula maturation and the fistula to get ready for it to be used for hemodialysis. So that time is very important. So what the guidelines, if you look at the Kedoki guideline, they say fistula first approach. Whenever the patient is in CKD 3, 4, get a fistula done. He may not need a dialysis immediately. Get a fistula done, let it keep working, give it some time. So that is the ideal time. So yes. That may not be possible in every case. Patient comes with sudden worsening of so CKD 3 can jump to CKD 5. That is end-stage renal disease. Can come with pulmonary edema, volume retention, blood fluid retention in the body. In those cases, we cannot do a fistula. Yeah. Then what we consider is temporarily use a catheter and in the same time do access as soon as possible. And yes. Then use it later on once it is ready.
Yes. Next.
So indications of AV fistula is a chronic renal failure and end stages of renal disease is the indications for the prolonged hemodialysis.
I think these are the clear-cut indications, sir, as you have explained.
Yes.
Yeah. Click.
So next type of AV fistulas in the radiocephalic fistula and the brachiocephalic fistula. The radiocephalic fistula is connected with always radial artery with the cephalic vein, and the brachiocephalic fistula is connected with the brachial artery with basilic veins.
I think these are the two very common type which we would like to know.
Yeah, these are fistulas are not limited to only these things, but these are the most commonly done fistulas. We do various permutations and combinations in the upper limb. We use ulnar artery with radial artery, basilic vein with radial artery, cephalic vein with ulnar artery. It all depends on patient variation to variation, but most commonly, over 90% of the patients will have either a wrist fistula. Wrist is the radiocephalic fistula, or the patient can have a brachiocephalic fistula. These are most common types of done
Fistula. Yeah.
fistulas, and this is generally what is needed for the audience who is present right now.
Next, Asha.
So risk factors for AV fistula. So older age, cardiac catheterizations if the procedure is involved blood vessels in the groin. So medication like anticoagulant, it may cause for hematoma or bleeding. So high blood pressures or increased body mass index. So it is mostly obesity.
So I think we all will agree these are the common risk factors.
Risk factors in the sense the risk factors for failure of an AV fistula. Elderly patients tend to fail, previous catheterizations tend to fail, patient on anticoagulation tend to create complications, fistula site bleeding, hematomas. Patients with high blood pressure can immediately post-op they can present with fistula site bleeding, because we are doing the surgery on the blood vessel itself, on the artery itself. So if the patient has got very fluctuating blood pressures and all, because these patients are usually hypertensive, their BP will be over 160, 170 systolic. So if the patient is hypertensive and not well controlled, immediate post-operative complications like bleeding from the fistula site will be very common. Obesity matters when if the patient is very obese, even though if you do the fistula, it becomes very thick. It should be very superficial, just under the skin. The cannulation might be a difficulty. The complications of arising in this group of patients will be more when we do an AV access surgery.
Oh, yes. Yeah, Asha. 8th slide.
Next. The normal AV fistula, it is connected in the AV fistula needles during dialysis. The abnormal AV fistula is the bulging of the veins, we can see in this picture. And next, arteriovenous cannulation, it was done in dialysis department. A dialysis technician, he is doing these procedures. So then AV fistula with the separate tubings. Always we have to connect the blue color connector with always with the vein, and red clamp always connected with the arteries.
Yeah, and the thing is that there is no artery connection as such. So both the cannulas will be inside the vein only.
Inside the
vein. When we divide this the vein, whatever is created, the fistula, whatever is created, into an arterial side and an venous side. So you cannot cannulate the artery per se because it will get thrombosed. Thing is, the nearer, if the cannula which is placed closer to the surgical site or the anastomosis per se is the arterial side. That is where the blood will go from the tubings into the machine, get filtered in the machine, and then come back to the venous side. What they ideally say is there should be at least of 10 to 15 centimeter gap between the arterial puncture, arterial side puncture, and the venous side puncture. So the more the distance, the recirculation of blood will not happen. That's a more technical issue. Try to maintain as much as possible. Around 10 centimeters is also fine. One needle towards the surgical scar will be the arterial. That is where that tube will go to the machine. It should not be the other way around. So that will usually be a red. Red usually indicates artery. So that machine will go to the, that tube will go to the machine, and then from there, you give it on the tube after once it gets filtered, it will come back to the venous side. Venous side where the pressure will be slightly lower. So that flow, that filtered blood will go into the circulation. So this is the whole this thing. That is how they are classified, red and blue.
Yeah, though we did not know this classification. Thanks for giving.
It's not a classification, it's just clinical assessment.
Yes, yeah. Go to the 11th, Asha.
So thrombosed fistula is showing in this picture.
Okay, the thing is that is not a thrombosed fistula. It could be, we don't know, we have to assess clinically. When we say an abnormal fistula, A failed fistula is also an abnormal fistula. When there is no thrill, the fistula is failed, it is blocked off, is also an abnormal fistula. A bleeding fistula is also an abnormal fistula. A
So when do
fistula
we
which is not
identify?
connected completely to the heart can also be an abnormal fistula.
So when we can recognize that this is not a normal fistula, right?
Yes.
Right
So
from
when we try to see what an abnormal fistula is, we should understand what a normal fistula is. So
Okay.
normal fistula is the surgical scar should be neat, clean, no discharge from the surgical scar, and it should have healed completely. There should not be any swelling, no discoloration at the operated site. This is the first thing what we have to see. So when the surgery is done, once the wound heals, there is no swelling, no discoloration, no pus or no water coming from the wound. So that's a normal scar. After that, once you see beyond the scar, that is proximal to the scar, if it is a radiocephalic, just beyond the rest or in the foam, if you keep your hand and see, you'll be able to feel a thrill. Thrill is the movement of blood, the turbulence of flow in the blood in the vein will give a thrill. So that thrill should be adequately felt. Ideally, 15 to 20 centimeters of thrill should be there. It depends on when the fistula is done. If it's a matured fistula, you feel the thrill more. If it's a fresh fistula, if it was done last week or maybe 1 week, 10 days prior, the thrill might be little less. So if you are not able to feel the thrill with the hand, you have to auscultate with stethoscope and see how far the thrill is, if the thrill is there or not. There is a difference between a pulse and a thrill.
Yeah.
If it is a pulse, again, it's an abnormal fistula. So if you feel that murmur is not there, that thrill is not there, you have to inform one of the doctors or your seniors. That is very important.
Yeah.
If you feel a pulse means that there is an obstruction somewhere in the blood flow. If that obstruction comes out, that the thrill will go.
Yeah.
That is one thing. Third thing is there should not be any swelling of the arm. See, what happens is some patients will have a neckline before, and following which we do a fistula. In between doing the neckline and the fistula, there will be a gap of 1 month. During that 1 month, what happens is this neckline would have created a problem inside the chest, wherein all the veins in the upper limb go and meet that same vein and go to the heart. So if there is an occlusion there because of our tube, what happens is once we do the fistula, the entire arm will get swollen. This is a picture what we are seeing. This is most probably what is called as venous hypertension. That means that the fistula is working, but fistula blood flow is not circulating all the way to the heart. If it is not going to the heart, because of that back pressure, you can see the swelling, which looks like elephantiasis. You can see that it's a very swollen limb. So that is typical of a venous hypertension. We need to address the occlusion, which could be because of the previous catheterization.
Over to you, Asha.
So his healthy fistula. So before during dialysis, so we have to prepare the part for dialysis and the sterile technique we have to follow.
Yeah.
So pre-procedure care. So check for any allergic reactions of any medications. Hold anticoagulant if anything is there prior to surgery before 5 days. And surgical site preparations always mostly we are collecting left hand. And NBM midnight onwards you have to keep. And diabetic, if the patient is on diabetic, so glycemic check is very important part. And start any IV fluids as per the conditions.
So I think these are the pre-procedure care which we all nurses must follow before we shift the patient to operation theatre for the procedure. Next.
Yeah, one thing I would like to add is don't try to start any IV fluid as such.
Yes.
Because these are already end-stage renal disease patients who are retaining fluids inside the body. Their kidneys are not functioning, no urine is coming out. So we usually avoid giving IV fluids unless it is dire necessary. If the patient is going into hypoglycemia, only then we think of giving dextrose saline. So that is one thing. Second thing is always have a cannula in the opposite limb. Whenever if we are doing it on the left side, the right side should have a cannula because sometimes in emergency we need to do that. So pre-procedure care, try to have an access, look for allergies, everything is fine. So try to get an access and don't start IV fluids per se. That will depend on per patient to patient, then we can take it.
Thanks for the correction, sir. Now, Asha, next slide.
So immediate postoperative care. So hand hygiene is a very important part and check radial pulse and color movements and warmth and sensitivity affected the limb to ensure the blood flow reaches to the extremities. Nothing wet. The capillary refills we have to check. Assess the pain levels and monitor vitals, especially hydration status, elevate the access arm, so providing the resources, monitor any signs of immediate infections or hematoma, and escalate immediately.
Yes, these are very good points here. Check radial pulse. That is the most important pulse, because sometimes what happens is if you do a brachycephalic fistula, the pulse below will go. So that is very important. If the attending nurse feels that there is no radial pulse, she has to alert immediately, because it means so many things.
Yes.
Second thing is monitor the pain level. Pain should not be excess. It should be a decent amount of pain, and it should not be patient should not be crying of pain because of any fistula. That indicates that there is some nerve damage or somebody has tied the nerve, and all those are also important. So along with that, the local site infection, that's a very good point what nurses should do. They should always look just before sending the patient. These are all daycare procedures. Yes. Just before sending the patient, the nurse should look at the operated site. If there is any swelling, that means that there is an hematoma which has occurred, which has to be escalated and immediately informed.
So request all the nursing staff to follow these immediate post-operative protocol as soon as you receive the patient from the OT. Next slide.
So fistula maturation, so it will take 6 to 8 weeks, ideally more than 12 weeks. The process by which fistula becomes suitable for cannulation or not, we have to check. So adequate flow should be there, and wall thickness and diameter we have to check.
So I think, sir, after this fistula maturation only we can start the dialysis treatment. Is this so?
Maturation mainly means that the fistula has the vein has dilated significantly, so that it can take that amount of blood flow through the veins. Along with that, it also has to take the large catheters, large needles which we place there. If it's a very small unmatured vein, it will just thrombose off, it will just block off. So we are waiting for the blood flow to increase, the size to increase, the thickness to also increase. So there is simple rule of 6 what we follow. The rule of 6 is the vein size should be approximately 6 millimeters. It should dilate to a size of 6 millimeters. And the flow should be 600 ml per minute. Yes. Per minute. And the depth is 6 millimeters, just under 6 millimeters from the skin. These are all just andaj we can see. We can just guess that that flow is good. If you have any doubt, then we can always get an ultrasound and look for the size. Next slide, Asha.
So fistula for radiocephalic vein, we have to follow some don'ts. No too tight accessory to be worn. So should not wear any type of bangles or wristwatches. We have to avoid all the things.
Yeah.
So if the patient is having fistula, so we have to put a ID band for do not prick the hand. So should not tie any tourniquet, should not prick for any IV cannula or blood vital checking, like BP. These are all the things we have to avoid for particular patients. So do not prick for blood sampling also. This is we have to avoid. All the renal failure cases, we have to keep this ID band first in left hand. So ideally weight checking, pre and post-operative dialysis is mandatory for all renal failure cases and document. Assess the patency of the fistula site and palpate the thread and listen to fluid sound. It means, so auscultate the fistula through keeping the stethoscope and through the AV fistula site and listen, gush of stitching sound is heard. This is nothing but root. And palpate the fistula site with the 3 fingers and listen, so palpate the vibrations. This fistula is working good.
I think as we have discussed and sir has already highlighted about this earlier this slide. Yeah. Next.
Inspect the arm for a suspected infection or inflammations before doing any dialysis. So risk of AV fistula creations. Infection is a 20% of all AV fistula procedure complications. So any swelling or redness of the skin or inflammations, it is an indication for AV fistula infections. It can be easily treated.
So what are the most common, cause of infections, sir, related to this?
See, the thing is, these end-stage renal disease patients, the immunity is already very low. Along with that, some patients will have an already pre-existing catheter in the neck, which will be the source of infection, and that infection will be running throughout the body.
Yeah.
So when we do a fistula, we always try to have a neat and clean this thing. We don't like putting a catheter first. That is why the whole idea of fistula first approach has come. But in the real world practice, when we see because of catheter site infections, low immunity, patients can develop infections that, as Madam said, like up to 20% of these fistulas can develop some form of infection, may not be very fulminant infections. In very mild infections, a small serum also can occur. That these are the most common. Along with that, these patients will be diabetics, their history of multiple punctures in the upper limb also. So that is where the infection usually comes from. And very small risk of surgical site infection because of procedure per se also can occur.
Yeah.
So advantages of AV fistula. So less tendency to clot, lower infections and hospitalization, greater blood flow, long-term patency.
Yes. Yeah. When you compare fistula with the catheter, these are all the advantages what we have. Apart from the initial maturation time, that is the only disadvantage I think. If it matures and if it is ready, it can be used for a longer time. 4 or 5 years is not usually a problem.
So disadvantages includes slow and failure of maturations, increase in size with age, aneurysm formations, and cosmetic appearance of dilated veins.
Yeah. Aneurysm formation usually occurs either because of surgical site infections or it can occur because of puncture site also. Because you repeatedly puncture the same site, you tend to damage the vein at that point, that particular point. So over a period of time, it slowly swells and it becomes a venous aneurysm. These are the few don'ts I would like to answer once it's done. Very important points I'd like to make.
Go to the next slide, Asha.
So patient education is very crucial part. The skin around the AV fistula site to clean with the antiseptic solutions. Avoid tight clothing and jewelries or wristwatches. Avoid sleeping with excess arm under the head or pillows. Avoid carrying heavy objects in the AV fistula hand. Do not do report in case of any severe pain in the AV fistula site or any hematoma or redness or one. Avoid exposure to extreme heat or cold. So the fistula may be need 6 to 8 weeks to mature, ideally more than 12 weeks.
I think you will agree with the tips which we would like.
Things what I'd like to mention here is what are the don'ts from the nursing team, what nursing colleagues, what we want. One don't is before surgery, few don'ts are before surgery, and few don'ts are after surgery. Before surgery, if the patient is coming to the nurse for a blood sampling, always try to look at where the patient is coming from. If the patient is coming from physician, it's fine. If the patient is being particularly referred from a nephrologist developing a kidney disease, always try to avoid puncturing the left upper limb. Try to leave one upper limb as clean as possible without any puncture mark. That is the most common. What we usually see is patient will have a nephrology consultation, get a prick in the left upper limb, and then afternoon he'll come to the vascular surgeon for an AV fistula. That is a very wrong situation and a very wrong precedent what we put up. The nursing staff has also a responsibility in looking at what the doctor has written. The doctor has written, nephrologist has written CKD, suspicion of end-stage renal disease, because you just look at what the investigations you are getting. That is not the wholesome picture what we have to do. Look at what the doctor is suspecting. If he is suspecting CKD, don't put a needle on the left upper limb. Even if you have to put, you find that there are no veins in the right upper limb, you want to try to take it as distally as possible, right? Maybe from the palm or just above the wrist, you can try to take. If you puncture at the elbow, you're damaging the vein. You're not only damaging the vein at that point, because and below that also the vein gets damaged. Because I cannot do a fistula once you're punctured in the elbow, I cannot do a fistula in the wrist because that flow will not be complete up to the heart. That is where complications usually arise. These are the first important thing from the nursing team, what we want to change the habit. Second thing is even post-surgery, patient, when you check the BP, don't try the BP on the left upper limb, wherever the fistula is there. When you do any sampling, be careful that there is a fistula. Don't give inadvertent injections in the left upper limb without looking at hand. These all things have happened very rarely, but they still have happened. That is what we have to change the habits, and you have to give instructions clearly to the patients about how to maintain. The patient has to do a ball exercise, that is hand gripping exercise regularly. If the patient is inside the ward, he has to be instructed regularly. Once the fistula is done, you can give a gap of 2-3 hours and the patient can start doing exercise. Just give a small smiley ball, he can start doing the exercise. These are the first thing. But instruct the patient very clearly, because we only see the patient for hardly 2 minutes, but you are there for hours together with the patient. They are more exposed to nursing team than doctors. So a clear-cut knowledge how to maintain the fistula, how to do the dressings, how to maintain the fistula. They should do a self-check also. Patient should see the thrill every day in the morning. If he feels that there is any problem, he should contact the doctor immediately and come. Yes. Those instructions should come from the nursing side. Yes. These are a few small things which I'd like to, which I wanted to add to this meeting.
Thank you for telling us all those instructions. We would definitely urge all the nurses to follow the same. Come to the next slide. I think we have come to the conclusion part. Share the slide, Asha. Yeah, AV fistula creation is opportunity as well as challenge, as you have discussed already, and mostly the problems likely to occur due to the stenosis or especially for the diabetic patients and all, and etc. So thank you so much for the very well acknowledged and very good session we have heard from you. Thank you, Asha, and thank you, sir. That's today the end of the session. Thank you.
Thank you.
Thank you, madam.
Thank you.